Yes, much better. On that day, though, I was almost unable to speak. Today also, you might feel some change in the voice. Fever has subsided. Yes. God's grace without any medicine. But yeah, it was a bit bad. Tomorrow morning there is race, 32 kilometers. So what I've done today is, so these were the pages which we already discussed, right? Some things I have already pre-written. Just few of the criterias. So that I have to speak bit less, and at the same time things are ready, so we can discuss more on it, and then we'll see all these ECGs in detail, right? Because there is so much of them to see. All right, let's go back. Yes, good evening. We'll wait for 2-3 minutes. For these 2-3 minutes, I'll tell you what I did in last 2 days. I read 2 books. I'll show you the books. The first book which I read was this. This is Calling Sehmat. This is based on a true story. If you remember, there was a movie called Razi. Remember that? There was a movie called Razi. Alia Bhatt, where she got married to, you know that. So when she got married to a Pakistani officer, army officer, and she was the spy. Now, I actually saw 2 days back, I saw a video of Harinder Singh Sikka. And what he said, that compelled me to read this book. What he said is, because this particular movie, now say you being young generation must know these things. If you have seen this movie, the movie was like, this was the story in nutshell. But then what happens at the movie is fine. Actually, when you'll see the book, in that, at the end, when she transfers the information to the Indian army, and then there was war, and then so many people died, and then it was shown that yes, she was in so much of grief, right? Itni dukhi, because of me, so many people died, this, that, etc., etc. Now, this Harinder Sikka, he is actually an army person. The book which he has written, he said that I was very proud of myself. But when one of the conference, when he was talking to someone, and he said, "Okay, boss, my mother is much more powerful than you." And then that person told him about Sehmat Khan, right? She was the person. So Harinder Singh Sikka in his interview said कि मेरा पूरा गर्व खत्म हो गया, मतलब मुझे लगा कि मेरे से भी महान तो कोई है. And then I searched for this particular lady, and I searched for this person, for almost 1 year. And then after that detailed research, this movie was written. This story was written. This story, once it was complete, then this book was given when he was in Mumbai. It was given to Gulzar. Now Gulzar said कि मेरी बेटी है, उसके पास काम नहीं है, वगैरह वगैरह. And with all these things are there with proof, right? Now her daughter Meghna Gulzar, she is a leftist. Now I'm not giving any opinion, but it is like I feel yes, India is going progressing at a very good rate, and yes, it would be a great thing. And I mean, I don't have any problem in showing you the things, but say I worked on say some investments and regarding that how to really go for it. I'll show you, okay? Because it is hundreds of pages. But the thing is that she was a leftist. Now this leftist, it is a word which is used. Is those people, they feel that giving gali to Narendra Modi is good, right? Showing that India is doing nothing, India is not progressing, it is good. Yeah, there is a specific group, and it was given to this Meghna Gulzar. She created a movie on that, and that movie is Razi. If you really read this book, right, in that book, in that movie, I mean, this heroine, she kills her brother-in-law, right? And then it is said that Indian army told her, right? Indian intelligence told her that you kill that person. The real story is she was such a powerful girl, and she was so much patriotic. She took the decision by herself to kill that person. She said, "Mere liye my India is first, right? So anything else is secondary." And she kills with a complete stable mind. And then she returns to India. And when she returns to India, she touches the earth, right? Bharat Mata. And then she said that yes, it was in this. I am lucky that I am given this opportunity. And that's the final chapter. While in the movie, it is shown that yes, she is very dukhi, and because what they have done, and during yes, and this Harinder Sikka, when he told this Meghna that what have you done? Why so much of manipulation? So she said, okay, sorry, right? But it was only a telephonic conversation. Never ever there was anything. So much so that even in one of this book particular, this is by Penguin Books. The release of this book was delayed. It was launched after the movie, right? So, no, today we have not yet started. Don't worry. So this is what I read in these 2 days. There was one more book, but now let's start with our topic. Okay, so it's time. Let's start. So here it is, hypertrophy, right? The ventricles, there is increased muscle mass, and there is increased voltage and the increased vector. University lecture at 6:30. So 6:30 is, we have got 1 hour, na? No problem. We'll be able to complete. So because we have written so many things, so we'll be able to save the time. Okay. So hypertrophy, increased muscle mass. When the muscle mass is more, right, there is more voltage, bigger vector. So that's for ventricle. For the atria, there is decreased muscle mass, right? But the walls are dilated. So that is what is called as atrial dilatation. And that's why we say left atrial enlargement or right atrial enlargement. Right? And this is the Buckman's bundle. You know that, right? This is the Buckman's bundle, which is the branch which is going to left atrium. Now here it is, the SA node. It is showing, it is sending it to right atrium and the left atrium, and it will be leading to the formation of the P wave. First half of the P wave is by right atrium, second half is by left atrium. But when the left atrium is enlarged, it will become biphasic because current is still going away. Right? This is what you will see in V1 or V2. The current is still going, so that's why we'll be getting the biphasic wave. Right? This is what is called as the biphasic. First half right atrium, second half left atrium. That is what you need to remember. For the atrial enlargement, biphasic wave, when do we really call it? Atrial enlargement, yes, it is seen in mitral stenosis, because mitral stenosis, so it will be creating pressure on the atrial side, right? And that's why the atria would enlarged. So that is for the left atrial enlargement. Left atrial enlargement, E wave, second half, it should be more than one small box. Similarly, when there is right atrial enlargement, first half, that should be more than one small box. Right? So this is what will look like. So in right atrial enlargement, it will be looking something like this. In left atrial enlargement, it will be looking something like this. Right? So this would be more than one box. What is one small box? We'll just see that. Okay, here it is. Say, I'll just zoom this thing. The entire paper is divided into these boxes, right? It is like a graph paper. So these are called as the big boxes. But if you can really see that in every big box, there are 1, 2, 3, 4, 5, right? There are 5 rows and there are 5 columns. So in every big box, there is one small box. So this is, if I just mark it, this much is the small box, right? It is 1 mm. 1 mm by 1 mm. So that is the small box because everything is plotted on the graph paper, right? Okay. So here it is, right? Very quickly. This is what we used to watch into our last session. So when we say that this is V1, 1, 2, 3, right? 1, 2, 3. AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. This is the order in which it will be placed. In order, if there is any deviation, right? If there is any deviation, we just watch V1 and we just watch 1 and AVF. So here it is plus and here it is minus. So just plus and the minus, and we decide this is left axis deviation. Right? And degrees also we can count. But what I really want you to see in this case is that there are 2 waves. One is the R wave and one is the S wave. You can remember it easily like R is rising and S is sinking. Right? R is rising and S is sinking. So all the top waves above. So this is the S wave. This is the S wave. S wave. Right? Over here it is the S wave. And then as we approach towards the V5, V6, right, it starts disappearing. Here it is, you can say that this is quite isoelectric. This is quite isoelectric. So that's why there is not much of the ventricle, much of the enlargement. Now, we'll see that here it is. So this is the new stuff. I wrote it final over here because today is the final session of our ECG. So here it is a hypertrophy. When we say hypertrophy in ventricles, there is increased muscle mass, there is increased vector. In atrial dilatation by phasic wave, we talked about it, atrial enlargement. In V1, right, when we see this, right, more than one small box. and in case of left atrial, there is one small box. Mitral stenosis and persistent hypertension, we talked in detail about it, right? They lead to this. Important is that in lead 2, the P wave will be more than 2.5 small box, and this is what is called as the P pulmonale, right? P pulmonale. When you see this thing, this is quite a big indication of right heart failure, right? This is something, this is how it would really look like, and this is called as the monophasic. Monophasic means things are going into only one direction, right? It is not going into the other direction. If it is going into other direction, like we see it over here in V1, so then it is called as the biphasic. Right? Yes, you are right. Okay. Here it is a normal R wave progression. And that's what we saw in the previous ECG also. So we start that S was seen, and then as we approach towards the V6, S disappears or it is very small. And then R, it becomes bigger and bigger and bigger. The logic is very simple. Logic is that here is the left ventricle, here is the right ventricle, here is the left ventricle, here is the right ventricle. Left ventricle is bigger, and all the V1 all the way to V6, right, they are arranged like this. So obviously this is away, V1 is away, V6 is near. So strong signals, when the direction will be, if the direction is this, so as you go towards the V6, waves will be bigger and bigger and bigger, right? Okay, Bhaisha, I'll send you the link. If you have mailed me, I'll definitely send. Just after the lecture, I'll send. So V1 to V6, as you go towards V1 to V6, current intensity increases and it becomes bigger and bigger and bigger. Now watch it over here. So this is a case of LVH, left ventricular hypertrophy. Now in left ventricular hypertrophy, what we really see is, this would be a very small R wave, right? R wave. It is R wave, right? And then the R is increasing, right? And this is the deep S wave. So here the pattern itself is fine, right? Because we say that R wave should increase. Yes, R wave is increasing. R wave is increasing, right? R wave is increasing. All good, right? So this is not telling that there is any problem. It won't be, na? Because even if there is any hypertrophy, the pattern will remain same. As we approach towards V6, more and more current will be coming, right? So how to differentiate? This is LVH criteria. LVH criteria is that is in V1, you measure the S wave, right? You measure the S wave. This is your S wave. So when we measure, we take big squares. So every big square is 5 mm, right? So we just take it like 5, 5, 5, and it has started from here and it is ending over here. So roughly another 5, right? 1 or 2 points here or there, doesn't matter. So this comes to about 20, right? I just remove this. You can see by yourself. You can calculate all the way from here to here, right? Here. So 1 box, 2 box, 3 box, 4 box. Yeah, almost 20, right? So this is 20. Then in V5 or V6, calculate the R wave rising, this one, only this much, all the way to this point. So this is 1 big square, 2, 3, 4, and almost 5, right? Almost 5. So this comes to 25. This is 20. So 20 plus 25, that comes to 45. It is more than 35. Yes, this is left ventricular hypertrophy. And I hope you have understood this, right? Because in ECG, once you'll see this, every time we'll be going through this part, right? It will keep on coming again and again and again, right? I'm just keeping it, just let it remain. The another thing is, you have to keep an eye on this, right? This is what is called as a T-wave inversion. Do remember this, very important point, right? T-wave inversion. Left ventricular hypertrophy, that is one. But when we say T-wave inversion in V4, V5, and V6, this is how things would really look like. See the T-wave which is over here, T-wave which is over here, T-wave. But suddenly, the T-wave has inverted. When the T-wave is inverted, right, so that is called as the stress sign. That is called as the stress sign, right? So this is one important thing. When it would be coming to right ventricular hypertrophy, in case of right ventricular hypertrophy, V1, right? V1, R is bigger than S. Because now see what would happen in case of right ventricular hypertrophy. Yes. We do have examples for everything, right? Now, this is right ventricle. Let's say this is right ventricle and this is left ventricle, right? The normal difference in size. But then this becomes bigger. Right? This becomes bigger. That means when we go all the way from V1 to V6, it is the more current which is attracted by right ventricle. That means the spikes which should be going big as we go towards the left ventricle, they will not be that big, right? So in such case, that is when this R wave, as you go towards the V6, which was becoming bigger and bigger, right? R wave, which was becoming bigger and bigger, right? Which was becoming bigger. It won't be that, right? In fact, these S waves, they will be deeper and deeper. They will be more deep, and then they will go become less deep because the current is called up on this side, right? So here, sorry. So here, we'll find that the wave pattern is going to change, right? And how it will be changing? R gets smaller as you go from V1 to V6. Makes sense, right? Because R is becoming smaller. R is large. Large. Why large? Because R would be, that is something, because this is big, right? This is big. This one is big. So R would be gets, and as you go towards V6, it becomes smaller. Right? As you go towards V6, it becomes smaller. V5, V6, normally S wave dies, right? S wave dies, but you'll find that S wave is still persistent over here. And then, obviously, RAD. This you will not miss, right? There will be RAD, because if right ventricular hypertrophy is there, right axis deviation is bound to occur. So in that case, you know this part, right? 1 and AVF we take minus and plus, minus plus. So that means there is a right axis deviation. If right axis deviation, we remember it like R2. Which one is isoelectric? If R is isoelectric, we say 120. And if lead 2, right? If not to confuse this lead, right? If lead 2, so then it is plus 150. Yes, go ahead. So keep on writing all the doubts and everything. Right? What is T wave inversion? Ulta. It becomes reverse. Right? See, this is the normal T wave. Right? This is the normal T wave. And then the T wave becomes like this. So it is called as the inversion. Right? This is called as inversion. We'll see the examples also. Left ventricular hypertrophy. See it here. I'll just remove this. Just going all the way from V1 to V6. What do you see? We see that R wave, as we go from V1 to V6, I'll draw it like this. R wave, it becomes bigger. This much is clear. Okay. Then S wave, which is bigger, and as you go, this becomes smaller. Right? So this is the pattern. This is a normal pattern. Huh? This is a normal pattern. Now, see this. I just removed this. See this, and don't worry. This is whether it is left ventricular hypertrophy or not. Or don't think anything. I remove this also. This patient's ECG is given to us. We just see V1. R wave is smaller. R is rising, right? So this one is R. This one is R. This one is R. This one is R. Yes, R is becoming bigger. Yes, all good. Then what about S? S is big. This one is big. This is big. And is it becoming smaller? Yes, it is becoming smaller, almost then going away. So this is a normal pattern, right? This is a normal pattern. But then the LVH criteria. This is V1. This is V1. In V1, pick up the S wave. This is the S wave, right? S wave is sinking. S wave. Measure the distance. Measure the height. So 1 square, 2 square, 3 square, and 4 square, right? It is slightly more than that, but roughly 4 squares. Every square is 5 mm. So this comes to 25 in the color. Sure. So this is 20, right? And then next is V5 or V6 R, right? So here it is. 1 big, second big, third big, fourth big, almost 5. So this is 25. 20 plus 25, 45. 45, yes, done. This is LDH. Now you can write because you have followed the criteria. Okay. And then will there be a left axis deviation? Definitely there will be left axis deviation, and you know how to figure out that. Correct? Okay. But when you see this thing, the second thing you don't have to miss is the T-wave inversion. Reflexly watch for that is V4, V5, V6. Are they inverted? If they are inverted, this is called as the stress pattern. Stress pattern. Right? It is called as the stress pattern. This stress pattern is not good. That means heart is taking load, and it might get converted into myocardial infarction. Right? I'll show you the examples also. Now clear? So that was. Now this is a very special thing. This is what is called as the Karnell voltage criteria. Karnell voltage criteria. This is like a lifesaver. I'll just explain. Right? And as because we'll be discussing cardiology, and now the new clinical topics will be coming from Monday. So at that point, I'll be going into more detail. But very easy. You just pick up V3. Right? Now at this point, it's a matter of under 1 minute you'll be able to understand it. You go to V3. In V3, just measure the distance, measure the height of S wave, right? That's sinking wave. And in lead AVL, measure the height of R wave. Right? Whatever the height it is. Send me a mail, right? Send me a mail, I'll send you the link. Right now, anything which is not related to the topic, right? I'll not answer it. I'll answer at the end because we'll deviate from the topic. Focus on this. So V3, measure the distance of S wave, and for AVL, measure the distance of R wave. Total. If it's male, so then it has to be more than 28. If it is female, so it has to be more than 20. Right? If this criteria is fulfilled, then within just by this, you would say that yes, this is a patient of left ventricular hypertrophy. This is what is called as the Karnell voltage criteria. There are several other criteria also, but regarding those criteria, this is very powerful. First, what we saw, which is based on the Einthoven's principle, and the second one is the Karnell voltage. This much is 99% of the ECGs you will be able to take a judgment from this. 99%. Right? These two, if you combine these two criteria, bahut ho gaya. Matlab it is even at someone who is practicing now, for them also this is more than enough. So don't worry. Here it is now. Chalo. Straight away, now we'll be going for our diagnosis. Right? So many ECGs are there, so we'll be doing very fast. Okay? Start. First thing first, what we'll see is there any axis deviation. So here it is, lead 1, right? And where is AVF? Here it is the AVF. What do you see? This is minus, this is plus. So fatafat, you can, yes, that's right. Right? This is what I want. Right axis deviation. This is right axis deviation. And can you figure out even the degrees? Fatafat, right axis deviation. So all we have to do is RN2, AVR N2, AVR. Right? Which one is isoelectric? Dekhte ek second mein khatam. Right? Which one? Shabash, 150, 150, 150. Very good. All of you are right. This is isoelectric. So yes, we are dealing with 150 degrees. Right? Yeah, I'll write it over here. 150 degrees. So this is right. Next, what we need really see is if this is right axis deviation. So so this means we are dealing with now right axis deviation. Is it because of right ventricular hypertrophy? For right ventricular hypertrophy, what we have to see is in V1, right? The criteria is in V1, we have to watch for R wave, right? And in V6, we have to watch for S wave. No, very easy. Think it like that on V1 side, the right ventricle is enlarged, right? So there will be big spikes. So is the R wave bigger? Yes. Here it is R. Here it is R. Here it is R. big R, right? This lower one, this entire thing, it is a rhythm strip, right? It is just the lead 2's rhythm strip. So actually, our just for the ECG, just consider this much, right? So V1, V2, V3, V4, V5, V6, right? V1, V2, V3, right? So that. Okay. Coming back to this, V1 is, so that's the R wave, right? This is the R wave, this is the R wave, right? And as you approach towards V6, right, it is becoming smaller, right? Yes, you are right. R is much bigger, right, than the S wave, right? Very good. So that is, and one more thing, which you would see. This is a very typical pattern. This. Normal ECG, when we draw the normal ECG, isn't it something like this, right? Like this, and then it becomes isoelectric, and then the T wave. Okay? This is normal. But here, see the change. This is, as it goes, this is the R wave, this is the S wave, this one is T. Now this should really go like this, and then it should go like this. But what is happening? The ST segment has gone down, right? I'll draw it over here for the understanding. It is something like this, this, and then that ST segment has gone down. This is the ST segment. ST segment. Watch this. Watch this. Watch this. This. And suddenly you will find, yes, the ST segment is down. This is ST depression, right? This is ST segment depression. This ST segment depression, that is called as the, this is for the right ventricle, right? So this is right ventricle. Same thing you'll be able to see in the left ventricle also. But because right now, right ventricle is enlarged, right axis deviation, so that's why we'll be calling it right ventricular strain pattern. Strain pattern. T wave inversion, that was for left, right? To remember, we'll see that example will also come, right? So this is ST segment depression, very important. And when we say ST segment depression, that means it is because of the decreased blood supply. Still, heart is not damaged. This is ischemia. There is a difference between ischemia and infarction. Ischemia means less blood. Less blood is good. Infarction is no blood. Right? Infarction means blood is not reaching there. So the cell dies. Heart will keep on working even if there is less blood, right? So this is how things would really go. When we say ischemia, you just compress your finger, right? You just compress your finger and then you see how it turns like, but still there is some blood. There is some blood. So that when it happens to heart, so that is the cry. Heart cries, that pain comes, and that is what is called as, this one will lead to angina pectoris. It is what is called as the angina pectoris. Angina pectoris, right? We'll be having one extra lecture on that, angina pectoris versus heart attack, right? So there is a difference between, because it is those important vital minutes, you see it and then you listen. Exactly, this is angina pectoris, it's like chest pain. Very right, right? You are very right. It is chest pain. And when there is no blood, it is called as the MI, myocardial infarction, right? Infarction. When the heart muscle cells, right, they die. Yeah, it is irreversible. Okay. Which part will be missed? Why do we call right ventricular strain? Right ventricular strain is better because here the right ventricular hypertrophy, right? So right ventricle is in focus, na? Right? We are watching the right ventricle. And this is right axis deviation. That means जो भी problem है, that is towards the right side. So that's why we called it right ventricular strain pattern. Same pattern we can see it in the left ventricle. When we'll see it in left ventricle, that means left ventricle would be enlarged. You know? Left axis deviation would be seen. Plus, there would be some other symptoms. So, right now, for this particular situation, we are calling it right ventricular strain pattern. This one. Oh yeah. Chalo, start immediately, right? The question would be always same. Is there any axis deviation? Yes, no. If yes, degree. Fatak. Right? Here it is 1. Here it is. Here it is AVF. Very good. Very good. Sharon. Shabash. Very good. And this should be that. Give the degree. Kushi, Sharon. Start writing with the degree straight away. Rishikesh. Degree bhi likhi dalo na. Shavani. Why only RAD? Write a full answer. Yeah, exactly. RAD 150 pass. This should be the thing. Very good. Right? So now you know how to calculate. Yeah, angina pectoris it can lead to myocardial infarction. Definitely, it can lead to, if not treated well. So no, they are not different. They are not different. But usually it happens like at times angina it subsides. Okay, so we'll discuss it more when we'll be talking about this angina and MI. Okay, so I'm straight away writing it that this is RAD with 150. Right, shabash. Next which we have to watch is that in this particular case, one very striking feature is, right? That striking feature is, watch this. This one. In lead 2, this P wave. Right? This P wave, see, normally P wave, we see it like this, right? Now, I won't be confusing you by giving you the detail, but otherwise, this is a very typical P wave, right? The P wave is not like this, but the P wave is like this, right? If you watch it very carefully, right, this part, but don't worry about it. Let me remove it. Right? Don't worry. Watch for this P2. In lead 2, in lead 2, watch the P wave. Right? This is P pulmonale. P pulmonale. And when we call it P pulmonale, when the P wave is more than 2.5 millimeter, right? 2.5 millimeter. That means 2.5 small squares. Now, no big rocket science, right? Just if we calculate it from here, so, and it ends up over here. This is like almost 4 squares, right? Definitely it is more than 2.5. I'm removing this so that when you get this file, okay, right? See, now you should be able to see it. If we start it over here, so this is 1 small square, this is 2nd small square, this is 3rd small square, right? Almost 3, right? Almost 3. So more than 2.5. So that's why this is definitely a P pulmonale. Okay. Next, take this. So when we say ischemia V1 to V6, that is when there is angina. When there is angina, so there would be the stress rhythm. Stress rhythm is there is inverted T wave. Right? One is the inverted T wave and the ST segment depression. ST segment depression. When it develops into infarction, so there is acute heart attack. Acute heart attack means ST segment elevated. Right? Remember, see, very typical. ST segment elevated. So this is how things would really look like. This is the ST segment, right? So this is the Q, R, that's the S, and all the way it should have come to this, and then it should have gone to this T wave, correct? But now it's not happening, right? All the way ST segment, it is elevated, it is lifted. This is a typical classical sign. See this. Over here, I want you to see V1 and VR. V1 is the best. Okay. Watch for this. Watch for this. This one. Let's zoom this because it is very typical. See, the wave should have, this is the baseline. This is the baseline. Right? See how it is going. This, and then this, that's how it is going. This is a superb case of P wave, which is biphasic P wave. That's right. It is the biphasic P wave. Right? And in biphasic P wave, we have to go for whether it is upper part is bigger or it is the lower part which is bigger. Right? If it is upper part, if it is upper, so then we are dealing with the right atrial enlargement. If it is the lower part which is enlarged, so then we are dealing with left atrial enlargement. In both the cases, what we have to see, whether it is more than one small square, right? More than one small square. One small square. Very clearly, you can see, right? See, it is this particular wave, right? This upper portion. So these are the small boxes, right? This is the one box, this is two box, right? It is definitely, it is almost 1.5 box, right? While this chota wala niche, so that is not even half a box. So yes, we are dealing with a right atrial enlargement, right? When it has to be more than one box. So diagnosis, the right atrial enlargement. Upper, that's right. That's right. Yes, this one. This one. This is V1, correct? I'll just zoom this thing. Or you can have a look at, this is sufficient. There is one more over there, but this is fine. See, this is the baseline, this one, this one, this one, right? Consider the baseline. Not normal. See, if I remove these lines, just think it like this. Here, and it is touching over here. More than one box, 1.5 box, biphasic. That's right. That's right, sure. This is right atrial enlargement, right? Because this upper portion, that is almost 1.5 box, and this is how it is going, right? So this is the RAE, right atrial enlargement. This one should be able to answer. I'll just say this. Now, shabash, very good. I'll not tell the answer. Nahi Khushi, this is a typical thing. Typical thing. Right atrial, there is definitely right atrial enlargement. This is a patient of pulmonary hypertension. I totally agree. But if you see this thing, you have to speak that word. Why? There is only one answer. A 4 small box. That's right. That's right. Yes, Deepika. Second person to answer it. That's the word which I want. Come on, yaar. अच्छा ये क्या है? What is this? Rishikesh? I agree. This is right atrial. Well, I just write it down. This is right atrial enlargement, and it is because of the pulmonary hypertension. Shabash, Rishabh, you are right. Yes, you are right. Why asking? That is, you are right. ST segment depression. Where is the ST segment depression? Not much. There is something which is more important, much more important. Typical. Typical. What is this? I am telling this is lead 2. अब तो बोलो. This is lead 2. This is no problem. This is P pulmonale. This is P pulmonale. And P pulmonale, when the P wave should be more than, P wave should be more than how much? It should be more than 2.5 small boxes or 2.5 mm. Let's write that. That's right, 2.5. यहाँ पे तो it is 1, 2, 3, 4 small boxes. So it is 4 mm. Definitely P pulmonale. And P pulmonale, once you see this, that means this is like pulmonary hypertension. Chalo. Yes. We got V1, V2, V3, V4, V5, V6. Right? Just limited. Not even the full thing is shown. So, what do you see? Should I mark? Should I zoom? Good. Yes, zoom user. Yes, Shweta, but be specific. Tanvi, you are right. Yes, Kushi. Why asking? You are right. That's right. Yes, Tanish. Bilkul, bilkul. You are 100% right. That's right. That's right. Rishikesh, normal nahi. You see, this, and then do you see a deep gap? Measure kar lo. See, the baseline is this, right? And it is over here. Almost one box, right? Almost one box. And if you compare this above one, right, it is just less. So the typical pattern, it goes like this. If you find this thing bigger, na, like this, bigger, and so that we call it left atrial enlargement. Right? Maybe. Don't worry. Always attempt. See, ECG is like visual perception. I told you this. Watch for this. Watch for this. Right? No doubt about it. Right? From the baseline, a very baseline is exactly over here. Right? Now it is much bigger than one box. Be bold. Be bold. Always think it like that. Whenever we are discussing, so this is like your home page. Make as many mistakes as you like. Right? And Shweta, it's very good on your part, right? When, in fact, I should have marked for this, but over here, yes, immediately it looks like, yes, it is of one size only, one box only. So, not possible. But yes, over here, it is definitely more. So, good observation. Right? Okay, chalo. Let's go further. No doubt, there are some other things also, but we'll see that. You're right. This is very nice. Chalo, all of you. On your toes, start. First thing first, axis deviation. Now, कैसे बोला? How did you say left axis deviation? Exactly, खुशी. That was the thing. Yes, Zoom user. दोस्त यार अपना नाम बदलिए. Zoom user क्या हर बार AVF कहाँ है? Yes, that should be the thing. Whether नहीं right axis या left axis छोड़ो. This is one. Where is AVF? AVF तो it is not seen. This. AVF is not seen. This. So we can't comment on it. But there is something else. Right? So let's keep this left axis deviation for time being. Right? In fact, there is left axis deviation. Right? But for time being, we just keep it on halt because AVF is not there. Right? So we write it like 1 AVF. So this is the ठीक है, it is plus. But then what about this? It is not there. We wait. Watch for another finding. Left atrial enlargement. And left atrial enlargement, you said it from, well, let's see the 2, this 2, right, lead 2. Are we getting anything, any clue in that? Is there any biphasic wave? Right? Is there any biphasic wave? Well, we are not getting any biphasic wave. We are not getting any biphasic wave. P waves, they are pretty normal now. So atria, right atria or left atrial enlargement will not be dealing with. Right? Because P wave is almost good. Almost good. Right? There is minor, very minor, right? This one. I'll show you the zoom part. See this one. This is a very typical way. Right? This is a very typical way. How it is going, as I was telling you like this. This is how it goes. So this portion is by right, this portion is by left. Very typical, this part. But right now, let's not focus on that. What you said? Just second. Check the lead P wave into lead 2. Bus, not in all of them. So watch for this. V1, V2, V3, V4. We said that in order to check for the hypertrophy, right, V1, in V1, which we will check? We'll check S. Here it is, right? This is V1 and this one is the S wave all the way from here to here. So this one is one big box, second big box, right? One big box, second, third, fourth, and some more, another 3, 4. So this is 20, 22, 23, right? Roughly 23. And then we have to add it to V5, right? And in V5, we'll be watching for the R wave, right? R wave. This is V5, not seen. So, but see, these waves, they are of V5, right? V5 is below. So, chalo, just calculate this much. This is 1, this is 2, this is 3, and this one, this much is 4. At least we can see this much wave. Right? So, even if we put it 20, yes, 20 plus 2, this is 43. It is more than 35. So yes, this is LVH. With this, we can say that yes, there would be the left axis deviation. Right? Left axis deviation. So this is how we can come to this conclusion. And when we say this is left axis deviation, so then accordingly you can calculate the degree also. Right? You know that. Okay. On to the next one. See this. What do we see? This is V5, right? It is V5. So V5, the moment V5 is seen, and first thing what we see in this V5 is the R, rising wave, because current is going towards the left ventricle, right? So let's calculate this rising wave all the way, right? It is going even beyond. So we just calculate it from this. So these are the three squares, right? These are the three. So 1 big, 2 big square, 3, 4, 5, 6, and then so at least 6 so they are seen. So this much is 1, 2, 3, 4, 5, 6. So 6 5 are 30, 32, 33, and at least 34. So this in V5, our R wave is already 33, 34, right? 33, 34. So in V1, S wave will be at least, say, 1, right? At least 1. So that means we are definitely dealing with left ventricular hypertrophy. And another thing, right? So left ventricular hypertrophy. And another thing which very nicely, who has marked it? दोस्त मुझे आपका नाम ही नहीं पता, हर बार so loser. Okay, swastika. I'll remember. So good. So very nice, because Sayali, you identify swastika, Sayali, Kush. 3% have identified. What else you see? Shweta. Yes. T wave inversion. This is a stress pattern, right? This is a T wave inversion you are watching, right? So this is with T wave inversion. Very good. Shabash. Yes. Very typical. Fatafat. Go in the same style here to everything up to 3, and everything is there along with the rhythm strip. See, basically nothing to worry. Sometimes 1, 2, 3 AVR, AVL, AVF. This much is the normal ECG, and rest is taken for the rhythm strip. Sometimes you want those extra, so then it is taken. Right? But yes, diagnosis is easy. Everything is in front of you. Very nice, very nice. Swastika, now I remember your name, but this is normal. This is 1. Then AVF. This is clearly downside mode. This is minus. So not normal, right? This is minus, this is minus, this is plus, AVF is plus, so that means we are dealing with right axis deviation. And then you can calculate, right? This is in AVR, that is over here, and this is 2. 2 is more, no, this is much better, right? So that's why this is 120. 120. Doesn't matter, right? So this is about 120. Important thing is that as we go from the V1 to V6, right, what do you watch? The S wave is persistent, right? S wave is persistent. Yes, there is inverted T. That's right. That's right. So here it is. The S wave is persistent. So this is definitely sorry. So this is the V1, right? As it is going, right? This is S wave. This is S all the way, right? This S wave is persistent. S wave is persistent. So S wave persistent. And yes, there is a stress rhythm, right? There is a stress rhythm. You identified that. So that's right. Right ventricular hypertrophy. True. So that's what we learned. Right now, last 5 minutes. So when it comes to angina, right? When it comes to angina, the chest pain, you immediately take the ECG. You will see that there would be the inverted T wave, right? Inverted T wave. That's what I said, Nisha. It's like a pattern, right? It's a T wave, inverted T wave. This inverted T wave, now I drew deliberately in this form, right? This is what is called as the stress rhythm. Stress rhythm. So just register this shape in mind and not this. Right? It is not like this, it is exactly like this. And later on, I'll tell you the reason also about why this shape occurs. Right? Okay. And when there is infarction, you'll watch there is ST segment elevation. Right? So we talked about it. So this is this, and then this, and it goes like this. That's the ST segment elevation. What's this? Yes. T waves, clearly T waves, right? Inverted, right? All the way. V5, V6, so much so they are seen even in V1, not in V1, but at least they have started appearing even into V2, V3. So clearly this is ischemia, right? Inverted T waves. See how easy it is? That means you'll tell this patient immediately take rest, right? No strain, because if sometimes if it isn't wanted, you start, if you see this thing, it goes like this, and then it goes like this, then you know that now what is happening, right? You can see in front of you that the wave which was going like this, and then the wave straight away it goes like this, wave it goes like this, right? R is also decreasing. That's right. Take this example. This is a real case. Just for the rhythm strip was taken. It is seen even above also, but rhythm strip was taken. But of what? ST segment elevation, exactly. That's right. See over here, right? This is the rhythm strip. Classical pattern. This is massive myocardial infarction. This is acute infarction. Remember the shape, right? This is heart attack. ST segment elevated. Okay? All of them. This one. Right? What do you see? This is ST segment. That's right. Depression. ST segment depression. And you know there is TMT test, treadmill test. When the patient runs on the treadmill, and then the ECG is taken real time, and then if this sign develops, immediately stop the test. Right? So in the treadmill test, right, also called as the stress test, this is called as stress. Stop the test immediately. It has to stop instantly, because this thing, otherwise it can become bad, right? And if it goes like this, and then it goes like this, first, then the attack has started. So never let it happen. As soon as this wave depresses, stop. Then we'll discuss about that what is the transmural, that what is called as the full thickness, endothelial layers, etc. With all these three panels. Chalo, fatapat, last one. Here, you'll be very much tempted with ST segment depression, but you have to remember it. The shape, this is a very different shape. This is like as if the inverted J is written. Inverted J-shaped pattern. It is that smooth. So it looks like that, but when the pattern, this is a pattern, is a very classical pattern. When it goes like this is called as J-shaped pattern. And in pharmacology, we'll study about the digitalis, right? Digitalis, which is also called as the heart tonic. Right? Heart runs like a horse, right? It is the digitalis. But when the digitalis is given in larger doses, then it leads to toxicity. It is called as the digitalis toxicity. And this sign is a classical sign. This is a classical sign of digitalis toxicity. So take this. You are very much immediately, yes. Why is it given? That is what we'll learn in pharmacology. But basically, if the heart is weak and you want that heart should really pump, so that's why this is for the, it is for the support to the heart. Because that's right. This looks like ST segment elevation. But what you must have noticed is that there is ST segment elevation. ST segment elevation everywhere, right? Here, 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 even here, right? So this is what is called as the global ST segment elevation. A very infarction is ST segment elevation. That's right. So the moment we see this, we say, "Kare, this is so khatarnak," right? Even here. But when you see so many ST segment elevation in every lead, shant, there is no emergency. Right? When there is global ST segment elevation, it is not because of infarction, it is because of the pericarditis. Pericarditis. In future, we'll be learning even more about it. But because this is one of the classical USMLE question, people make terrible mistakes in this. Right? So whenever there is global ST segment elevation, it is not an emergency. It is pericarditis. Pericarditis, you know that heart is surrounded by the pericardium, and in that when there is fluid collection, so it is called as the pericarditis. Right? Why it is important? In fact, the question is that. The question, the importance of it is importance of this global ST segment elevation. There is one, it is pretty expensive, but it is given in myocardial infarction. It is called as the TPA. It is what is called as the tissue plasminogen activator. It is called as tissue plasminogen. Though it is part of that pharmacology, but good to know that this is tissue plasminogen activator. What it will be doing, when there is heart attack, there is coronary obstruction, right? Coronary arteries, blood is not going through coronary vessels. We need to remove that. We need to, because why this coronary artery, it is blocked because of thrombus, that is the clot. Right? You can see this is a clot, and that's why this particular area, right, it is not getting any blood. We need to dissolve this clot, so that's why it is called as the thrombo. So this clot is called as a thrombus, right? It is called as thrombus. We need to kill this. We need to break it. So it is called as lytic. So it is the thrombolytic agent, right? So this tissue plasminogen activator, it is one of the substance for which is used for thrombolytic agent, and that is given routinely and it is very effective. But the trouble is, when you give this tissue plasminogen activator, because let's say we saw that yes, there is ST segment elevation, this is heart attack, chalo dalo tissue plasminogen activator given, and it has, in fact, there was no clot. Right? So what really happens is, if it is given in pericarditis, it will lead to a condition what's called as the pericardial tamponade. Pericardial tamponade is nothing but accumulation of more fluid into the pericardial sac. So it is accumulation of more fluid. In pericardial sac. Now, how bad? Pericardial sac. So, patient was having discomfort. Right? You can even the history will be very important. But if the ECG is given, this was the question of ECG. So, when the tissue plasminogen activator is given, in case of this particular ECG, what are the likely developments? And the answer was pericardial tamponade, because there is a global ST segment elevation. And if there is pericardial tamponade, so then the heart would look like a globular heart, right? Globular, because there will be collection of more fluid. So, and more fluid in the heart will be compressed. And once the heart is compressed, so that means there would be decrease in the cardiac output, and it is a bad outcome. Patient might die. This is bad. So that's the importance of the ST segment elevation. But if it is global, so then to take care. And that's why sometimes even the rhythm strips are taken, right? Multiple rhythm strips, V1, V2, V3, 1, 2, 3, lead 1. So all those long strips, right? Because it hardly takes 1 minute to go for long strips. And now that it is digital, so on your panel, everything is coming up. So not to worry, right? And plus the clinical sign symptoms, they are very difficult. So we'll discuss all these things. So that's it for today. I know, yes, some of you are having those lectures. So we are, yes, at 6:30. Okay, there were some questions. Okay, email. So those who have asked for, just a minute. This is the email. Quickly note it. Till you are Mbbs. Send a mail to me. I'll send you the link right now, where you'll be able to see. You'll be able to get all the PDFs. Yes, I'm scrolling up. It is TILL. You are Mbbs. Yes. Should I show you this part? Today's PDF I'll share within 2 minutes. As soon as I finish. Importance part. Last page. So this is, so if the tissue plasminogen activator is given, and if there is no problem in the coronary circulation, so it will lead to pericarditis. Right? Pericarditis will become pericardial tamponade. So there was collection of fluid, now the collection has become increased. Which one? That's what I repeated. So if the tissue plasminogen activator is given in pericarditis, it will lead to pericardial tamponade. This word itself means accumulation of more fluid into the pericardial sac. If there is more fluid, so here is the heart, which is normal, but now the more fluid, so heart will be compressed. And if it is compressed, it is bad. Okay, so wish you all a very happy weekend. All the reports, yes, I'm missing. Okay, so thank you so much. See you soon. Bye bye. Okay.